Welcome to our third lecture on imaging anatomy of the thorax. Previously, we have discussed the mediastinum, the pericardium, and the lymph node groups of the mediastinum. We talked about the cardiac anatomy, including the cardiac chambers, the blood supply to the heart via the coronary arteries, and the cardiac veins. So today we'll be focusing on the blood vessels, on the great vessels of the heart. These are the vessels that are coming out and going into the heart. So they will include the aorta, the superior and inferior vena cava, and the pulmonary arteries and pulmonary veins. And we will discuss the vascular anomalies of these blood vessels. So let's start with the aorta, which is the largest and the most important artery in the body, because it's the one that takes the blood out from the heart and push it or send it to the whole body circulation. And we will know that when there is some abnormality of the aorta, it's very risky. We'll have some images in which the presentation of the abnormality in the aorta will present very early in the life. It functions to carry the oxygenated blood that is pumped by the left ventricle through the aortic valve and take it to the rest of the body. Anatomically, it's divided into thoracic aorta and abdominal aorta. In the thoracic portion, we have the ascending, the arch, and then the descending. So this is how the aorta, the thoracic aorta looks like. These are the aortic sinuses, in which the coronary arteries are coming from. Then this is the arch, including the three branches in the normal populations. Then the descending. This is a long segment of the aorta, including the thoracic and the abdominal. So the aorta will be passing through the aortic hiatus of the diaphragm. When we talk about the diaphragm, we'll talk about this hiatus, passing into the abdomen and becoming the abdominal aorta and giving several branches there, and then bifurcates to form the two left and right common iliac arteries. This is a very beautiful map, which I really love. Yeah, because it summarizes the blood supply to the human body. Here we just took the portion of the thorax and a part of the upper limb. So here we have the ascending aorta, the aortic arch, giving three branches. From left to right, they are the left subclavian, the left common carotid, and the brachiocephalic trunk. On the left side, the subclavian artery will then give the vertebral arteries, the vertebral artery, the costocervical trunk, and some other branches, including the thoracocervical trunk and so on, and continues as the axillary artery. On the right side, the brachiocephalic trunk will bifurcate to form the right common carotid and the right subclavian. The right subclavian will have the almost similar branches at the left subclavian, except that it has this branch, which is the internal thoracic artery, which will give several branches called the anterior intercostal arteries, which will supply the anterior portion of the intercostal spaces. The aorta is then descending within the chest, giving several branches supplying the posterior portion of the intercostal spaces. So these branches are called the posterior intercostal arteries. So the posterior intercostal arteries are coming from the descending aorta, while the anterior intercostal arteries are coming from the internal thoracic artery, which is coming from the right subclavian artery. The right subclavian artery is then continuing as the axillary artery, supplying the upper arm. When we talk about the extremities, we will then review and study this part. This is an anatomic illustration of the blood supply. So, the ascending aorta, aortic arch, descending. Here are the anterior, the posterior intercostal arteries. Here we have this internal thoracic artery, which you have the anterior intercostal arteries. Let's talk about the anomalies of the aortic arch. The most common one, and the one that is most probably to be coming in the exam, if anomalies are considered, is the aberrant right subclavian artery. In this case, the right subclavian artery is not coming from the brachiocephalic trunk, it's coming from the aorta, and it has the different course. So it's the most common one, and in this case it's not a true ring, so it doesn't form a ring. We will see some other anomalies which form a ring, causing compression to the trachea and esophagus. It's usually asymptomatic. Sometimes it can cause dysphagia if there is a compression on the esophagus posteriorly. This is an illustration of the aberrant right subclavian artery. As we said previously that the aortic arch usually gives 3 branches, right? Left subclavian, left common carotid, and brachiocephalic. But in this case, it gives 4 branches. The 4th one is the right subclavian. But the right subclavian is here originating on the left side, the most left one, and then passing posterior to the trachea and esophagus, and passing to the right side. So this is aberrant right subclavian artery. The other anomaly is the innominate artery compression syndrome. Innominate artery is the brachiocephalic. So in this case, there is a compression on the trachea by the brachiocephalic trunk. This is more common in the children population, and usually resolves as they grow. This is an illustration of innominate artery compression syndrome. As we see here, the innominate artery is more to the left and compressing the trachea here. So let's have this image and guess what is the anomaly that is here. This is a posterior view. This is axial CT. Yeah.
So this is aberrant
right subclavian, right? So this is an incidental finding. So there is a right subclavian artery, which is the last brachiocephalic artery here, as we see. Then this is a 5-year-old girl with noisy breathing and occasional episodes of cyanosis. This is lateral topogram, axial CT, sagittal CT. What we see is there is a compression on the trachea, right? So what is this structure that is compressing the trachea?
The brachiocephalic.
Yeah, the brachiocephalic trunk. Because this is the left subclavian, left common carotid, and then this is the brachiocephalic trunk. So in this case, the brachiocephalic trunk is compressing the trachea, causing what is called innominate artery compression syndrome. Other anomalies of the aortic arch include the right arch mirror image. In this case, the aortic arch is on the right side, but it has the same structures that it should have if it is in the left side. That's why it's called mirror image. This is usually asymptomatic, and it is associated with congenital heart disease in 98% of cases, which means that when you see right aortic arch, you have to look for other anomalies, because it's always common with the other congenital heart diseases, mostly the tetralogy of Fallot. This is a case of right arch mirror image. The aortic arch is supposed to be here, right? But now it's passing to the right of the trachea and esophagus. But again, it has the right subclavian, the right common carotid, and here it has a left brachiocephalic, which will then give the left common carotid and left subclavian. This is what is called the mirror image. The fourth anomaly is the right arch with aberrant left subclavian. So here we have a right arch, but again, it doesn't have the same branches at the normal left arch. Here it has a right, the aberrant left subclavian. So this is it. So we have the aortic arch on the left side, but here the left subclavian is not originating from the brachiocephalic trunk, as in this case. Here it's originating separately and passing anteriorly here to go to the left side.
Okay.
Sorry.
So this is proximal to the brachiocephalic trunk origin. The
aberrant.
left subclavian artery.
Yeah, actually the left subclavian artery is this one. Is this one? Yes. Yeah, this horizontal one. This is the left common carotid. So it's the left subclavian, and then the right subclavian, the right common carotid, and left common carotid. So what's in here? This is a small kid. So what we see here? Yeah. This is a posterior view, 3D image. This is left and this is right. So
Right side.
That's what?
Right.
this is right and this is left. So it means that the arch here is in the right, right?
Right side.
Yeah. So this is a case of right-sided arch, right arch mirror image. This one. This is also right and this is left. This is posterior view. This is the left common carotid. This is the right common carotid, right subclavian, and this is the left subclavian. Yes. So this is the right aortic arch, right-sided aortic arch with aberrant left subclavian artery. Other anomalies of the aortic arch include double aortic arch. In this case, there is a complete ring encircles the esophagus and trachea, and in this case, we usually see what is called four-vessel sign. So the four vessels of the aorta and brachiocephalic trunk are now originating from these two arches, causing or making this four-vessel sign. Yeah. This is an illustration of double aortic arch. So on the left side there is one arch, on the right side there is one arch. One of them is large and the other one is slightly hypoplastic. And they completely encircles the trachea and esophagus, causing compression and becoming symptomatic in this case. A similar but with a little difference is the double arch with atretic segment. So in this case there is a large arch and a small arch, but there is a portion which is not totally patent. It's like a ligament. It's like this one. So this small ligament is completing the circle, but the arch is not complete on this side. So there is the right arch here and there is a small arch on the left side. There are four vessels here, making four-vessel sign. So this is a case of double arch with atretic segment. So what do you see here? This is chest X-ray, PA projection. This is lateral projection. This is the aortic knob, right? So this is normal on the left.
Yeah.
But what on the right here? We see that there is right parasternal or paravertebral mass or soft tissue. The differential for this one is either tumor, adenopathy, or a vessel, maybe right arch or dilated esophagus vein or dilated aberrant right subclavian artery. But when we have a look to the CT, this is a CT of the same patient, axial CT series, and this is 3D reconstructed posterior view. This is right, this is left. 4 visual sign. Yeah, true. Yeah, 1, 2, 3, 4. And yeah, double aortic arch, right? Yeah, we have double aortic arch completely encircling the trachea and the esophagus. It's more clear on this 3D reconstructed image. We have to notice that there is a compression in this case. So this is a long window. You see the compression on either sides of the trachea. This is another case. In this case, we also see 4 visual sign, but here the ring is not complete at this portion. This is this atretic segment. So this is double aortic arch with atretic segment.
So when you see the fourth visual sign, next thing is to determine whether it's a complete ring,
Yeah,
it's atretic.
yeah. Whether it is double arch with complete ring, yeah, or it is right-sided arch with atretic segment, or double arch. It's also called double arch because it forms a complete ring. This ring is not all a patent aorta. What's in here?
Atretic.
Yeah.
Atretic, right arch.
Yeah. So there is a dominant right arch here, and a small left arch here, and there is this atretic segment, and 4 visual signs. 4 visual sign. And this is the compression on the trachea. This is 2-month-old boy with heart failure. 2-month-old. What do you see? This is axial CT, 3D reconstructed posterior view.
See,
The arch seems to be on the left, right? So it's okay, right? This is the heart, this is the ascending aorta, this is the descending.
there's a stenosis.
Yeah, the descending here is very thin, very narrow. And the large thymus, this is actually the thymus here. The large thymus here is normal with the age. So at this age, it's still functioning. So this is a case of aortic coarctation. Aortic coarctation, we have 2 types. There is preductal and postductal. And we have to know the difference because the presentation is different. In preductal aortic coarctation, the coarctation is above the left subclavian artery, and there is hypoplastic arch. So here, the coarctation is prior to the subclavian artery. Subclavian artery is the first branch, right?
Yes.
Yeah. So in this case, the presentation is very early, and it's very dangerous because, as we said, aorta is the most important blood vessel. Yeah. Then the postductal is the coarctation that is distal to the left subclavian artery. There is a normal diameter arch, and in this case there are collaterals because this is a more chronic condition. There is time for the collaterals to develop. Let's have a look to this image. This is axial CT. This is sagittal view. Here we can see the ascending and descending, right? But here, if you notice, distal to the subclavian, to the left subclavian, there is this narrowing of the descending aorta. And there are these collaterals opening. So this is a case of postductal aortic coarctation with several collaterals. The collaterals are usually between the 3rd and 8th ribs. Yeah. Yeah. So this is a postductal aortic coarctation case with several collaterals. These are two cases. The coarctation here is proximal to the subclavian, to the left subclavian artery. So this is a case of pre-ductal type of aortic coarctation. Collaterals in this case do not occur, probably because they don't have time to develop. In this coarctation of the proximal part of the aorta, it will present early in the life. There is no time for the collaterals to develop.
Where the subclavian is reduction?
This one.
That the one you showed the small one is the subclavian.
That's okay.
Sure.
This one.
It's okay.
It says proximal to subclavian.
Yeah, proximal, it means more near to the heart, more near to the origin of the aorta. So we move on to the venous system. In the venous system, we have the superior vena cava, the inferior vena cava, and we have the esophagus venous system, which is slightly a bit complicated system, but we wish that we make it clear today. So let's have a look to this beautiful map. We already talked about the venous drainage of the brain, head, and neck. So we moved almost until we reached the internal jugular vein. Then the internal jugular vein, along with the vertebral vein and external jugular vein, will drain to the subclavian, and then the subclavian will drain into the brachiocephalic trunk. The two brachiocephalic veins are draining into the superior vena cava. So these are the brachiocephalic veins which are draining into the superior vena cava. The superior vena cava will also receive blood return from the esophagus veins and some other small veins. The esophagus will receive the blood from the accessory and hemiesophagus veins, as we will discuss shortly. So this is a general map of the venous system of the human body. Left and right brachiocephalic veins, superior vena cava. Inferiorly, we have the inferior vena cava, which drains the abdominal and lower limb venous blood back to the right atrium of the heart. This is anatomical illustration of these structures. So here we have the two brachiocephalic veins, the subclavian veins, the superior vena cava, and inferiorly here we have the inferior vena cava. And these are the esophagus venous system. This is SVC, superior vena cava, illustrated on this coronal CT image. So the contrast agent was injected in the left arm. So it was going through the left brachiocephalic vein here, coming back to the SVC. So this is the SVC entering the right atrium. What do you see here? Today we are discussing the blood vessels and the anomalies side by side. In this case, the contrast agent is coming through the axillary vein, right subclavian, brachiocephalic, to the superior vena cava, right? This is okay. What's on the other side? There's almost similar structure, right? So we have another subclavian, brachiocephalic, and what is this? It looks to be similar to the superior vena cava, right? True, it is. So this is a case of duplicated superior vena cava, where a left-sided superior vena cava is draining into the left atrium by passing the pulmonary circulation. So in this case, it's a right to left shunt, right? Yeah, because the venous blood is now coming to the left side of the heart. Okay, let's have a look to this CT series. Yeah. The superior vena cava is supposed to drain into the right atrium, right? Yeah, and therefore it's located on the left side. On the right side, true. Yeah, on the right side. So let's have a look here to the contrast agent followed from the axillary vein back to the heart. How was the course of the contrast agent in this case? The contrast agent is almost here. It's coming from the left side.
Into the left, right atrium.
To the right atrium, but the location is on the left, right? Yeah. What we saw here is a case of left-sided superior vena cava, in which it's draining into the coronary sinus. Do you remember the coronary sinus? When we talked about the cardiac veins, we said that they drain the venous blood back from the myocardium to the coronary sinus and then to the right atrium. So in this case, the superior vena cava is located on the left side, and this draining into the coronary sinus and then to the right atrium. We move on to talk about the esophagus venous system. What is the esophagus venous system? It is a collective term given to an H-shaped configuration of the esophagus, which is located on the right side, the hemiesophagus, accessory hemiesophagus, and left superior intercostal veins, which are located on the left side. So on the right we have only the esophagus. On the right, in the left we have the hemiesophagus, the accessory hemiesophagus, and the left superior intercostal vein. The esophagus venous system is responsible for draining the thoracic wall and the upper lumbar region via the lumbar veins and posterior intercostal veins. It is also important because when there is an obstruction of either superior or inferior vena cava, these are the compensatory collaterals. So they will open and cause collateral circulation. Let's have a look to this illustration from Gray's Anatomy. This is an illustration of the esophagus venous system. On the right side, we have the esophagus vein. On the left side, we have the left superior intercostal vein, the accessory hemiesophagus, and the hemiesophagus. Are we okay here? Okay. We'll talk about each of them separately. So the esophagus vein initially arises at the union of the right ascending lumbar vein, which drains the right side lumbar region, and the right subcostal vein around the T12, actually below the T12, below the last rib. So this is the esophagus vein. So it starts here as tributaries from the right ascending lumbar vein, this thin vein posteriorly, and the right subcostal vein, this one below the last rib, forming the esophagus vein. It then enters the thorax via the aortic hiatus in the diaphragm and ascends posteriorly alongside the vertebral bodies, arching over the right main bronchus at T5, T6, and enters the superior vena cava at approximately T4 level. So it's entering the superior vena cava here. This is T1, T2, T3, T4. So almost at the level of T4, it enters the superior vena cava. This is the normal course of esophagus vein. The esophagus vein receives at the same time the lower 8 posterior intercostal veins, the bronchial veins from the right lung, and is joined by the right superior intercostal vein superiorly. So the right superior intercostal veins the lower 8 posterior intercostal veins and the bronchial veins from the right. It also receives the blood from the accessory hemiazygos and the hemiazygos at the level of T8 and T7 respectively. In this illustration here, the accessory hemiazygos is then draining into the azygos at the level of T8, and the hemiazygos is draining into the azygos vein at the level of T9. There is a practical point which we should know when we evaluate the images, that the azygos vein contains a valve halfway the azygos arch between the vertical azygos vein and the point where the azygos vein enters the superior vena cava. This valve is a common site for the intravenous injected contrast agent to accumulate. So we should be aware of this valve. So when we see a collection of contrast agent at this area, we don't confuse it with pathology at this area. The other vein of the azygos venous system is the accessory hemiazygos vein. It drains the superior left hemithorax. So it arises from the 4th to 8th left posterior intercostal veins and lies longitudinally on the left side of the vertebral bodies. It also drains the left bronchial vein and some veins from the esophagus. Then, as we mentioned previously, it joins the azygos vein behind the esophagus at the level of T8. So this is the accessory hemiazygos. It drains the left-sided hemithorax. Sometimes it receives the blood from the left superior intercostal vein and these posterior intercostal veins, and drain into the azygos vein at this area at the level of T8. Lastly is the hemiazygos vein. This one arises from the left ascending lumbar vein and passes through the left crus of the diaphragm. It drains the 9th to 12th left posterior intercostal veins and the left subcostal vein alongside some esophageal veins, and then it ascends the thorax to the left of the vertebral bodies and passes behind the esophagus at the level of T9 to join the azygos vein. So this is an illustration of hemiazygos vein. It starts as the ascending lumbar vein and left subcostal vein. This is similar to the azygos, right?
Yes.
Yeah. And it receives the T9 to T12 posterior intercostal veins and then passes at the T9 anterior to the vertebral bodies and posterior to the trachea and esophagus. Sorry, posterior to the esophagus, there is no trachea here now. Draining into the azygos vein. So what we should know about the azygos venous system in the normal population is that it is this H-shaped structure. It passes alongside the two vertebral bodies, draining the thorax wall venous blood. There are a lot of variations, but we should know that the azygos vein is on the right and the hemiazygos and accessory are on the left. The variations are sometimes the hemiazygos and accessory hemiazygos vein form a common trunk instead of draining separately into the azygos veins. So they will not have these two draining part. They will have only one common trunk of both of them. Sometimes the azygos vein rarely drain into the right brachiocephalic vein. So normally it is draining into the extra pericardial superior vena cava. But it can drain into the right brachiocephalic vein, into the right subclavian vein, into the intrapericardial superior vena cava, or sometimes directly into the right atrium. These are all variations of the azygos vein. We should also know that these variations are not always congenital. Sometimes they could be acquired, because we talked previously that when there is occlusion of superior or inferior vena cava, these veins will open. So we will see some new circulations which are not identified usually. Another thing to notice is in case of fibrosing mediastinitis, there is maybe variable engorgement of these collateral veins. So let's have a look to this series here. This is an illustration of the esophagus venous system. So, on the right side, what we have here along the vertebral bodies is the esophagus vein. Yeah. At this level, there is this common trunk of the accessory hemiesophagus and the hemiesophagus draining into the esophagus vein. Here, the esophagus vein is normally draining into the superior vena cava, which is this vein. We move on to talk about the pulmonary vasculatures, including the pulmonary arteries and the pulmonary veins. So the pulmonary trunk is the solitary arterial output from the right ventricle, transporting the deoxygenated blood from the right ventricle through the pulmonary valve into the pulmonary arteries and then to the lungs for the purpose of oxygenation. It is approximately 50 millimeter long and 30 millimeter wide, and this is more important. Some others, or most of the others actually, use the 29 millimeter width as the cut-off of the normal pulmonary trunk width. So if it is above the 29 millimeter, it's considered abnormally dilated. It arises as a direct continuation of the right ventricle, separated by the pulmonary valve. At the level of the transthoracic plane of Ludwig, the trunk emerges from the fibrous pericardium and divides into longer right, because it needs to pass from the left to the right, and the shorter left pulmonary arteries. We also mentioned previously that the left coronary artery is passing at this region between the pulmonary trunk and the left of the left and the auricle of the left atrium. So this is an illustration of the right ventricle, pulmonary valve, pulmonary trunk, which is then dividing into the left pulmonary artery and the right pulmonary artery. The left pulmonary artery is shorter because the pulmonary trunk is on the left, and then the right pulmonary artery is longer because it needs to pass from the left to the right. The left pulmonary artery enters the superior aspect of the hilum of the left lung, dividing into upper segment, which is the upper lobar artery, and the lower part, which is the lower or the descending or interlobar artery. The upper lobar artery supplies the left upper lobe and lies medial to the left main bronchus. Sometimes it may arise directly from the pulmonary artery or from the descending pulmonary artery. The right pulmonary artery divides into upper and lower, same as the left one. The upper lobar artery, also called the truncus arteriosus, supplies the right upper lobe and courses medial to the right main bronchus. It's smaller than the descending interlobar artery here. And the descending is then supplying the right middle lobe and the right lower lobe and courses lateral to the right main bronchus. So the upper one is medial, the lower one is lateral to the right main bronchus. The pulmonary veins are the ones that drain the oxygenated blood from the lung back to the left atrium of the heart. A small amount of blood is also drained from the lung by the bronchial veins into the esophagus venous system. So there are typically 4 pulmonary veins, 2 draining each lung. So we have right superior, right inferior, and left superior and left inferior. The right superior drains the right upper and middle lobes, and the right inferior drains the right lower lobe. On the left side, the left one drains the left upper lobe, and the superior one drains the upper lobe, and the inferior one drains the lower lobe. The pulmonary veins course in the intersegmental septa, and this point is different from the pulmonary arteries, which goes along the bronchi and bronchioles, forming lobes, segments, and subsegments. But the pulmonary veins does not respect this kind of subdivisions. They usually pass intersegmentally. So let's have a look to this CT image, CT series. We review what we have learned of the pulmonary arteries and pulmonary veins. So here is the pulmonary trunk, or the main pulmonary artery. Then it's dividing here into the right, which is this long one, and the left, which is supposed to be here. It's cut. Then the pulmonary veins are these veins. Sorry. Yeah, these veins which are draining back to the left atrium. Yeah, these ones. We move on to talk about the anomalies of the pulmonary arteries and pulmonary veins. The anomalies of the pulmonary arteries include agenesis, or interruption of the main pulmonary artery, pulmonary sling, and ductus arteriosus, patent ductus arteriosus. What do you see in this image? This is a chest X-ray, an axial CT, with for a young adult who had cyanotic spells when he was small, and now he's doing well. These images were taken for another reason.
The chest X-ray shows a patient of the right hemiparesis.
Okay.
No discernible heart shadow, normal heart shadow.
Yeah, which means that the heart here and mediastinum is deviated to the right side, right? Okay, what will cause deviation of the mediastinum to the right side?
Either a collapse on that right side, or a contralateral tension pneumothorax. But in this case, it's most likely a collapse because of the white heart.
Yeah, true. And the left hemithorax is seen to be okay, right?
Yeah.
So it could be atelectasis, pneumonia, or maybe tumor that is causing collapse here and deviation of the mediastinum toward the right side. But when we have a look to the axial CT here, what we notice is this is the pulmonary trunk, right? This is the left pulmonary artery.
Yes.
And where is the right pulmonary artery?
Okay, on that level, I don't see it exactly.
Yeah? Okay. What if I tell you that there is no right pulmonary artery? Okay. So this is the case of right pulmonary artery agenesis. But what's happening here is there is a hyperinflation of the left lung. If you see that it's crossing the midline, right? It's crossing the midline from left to right. And there is deviation of the mediastinum from the center, from the midline here toward the right side. And there is remnant small parts of the right lung here, and there are these collaterals. So when there are these collaterals, usually there is some some kind of lung. So this is a right pulmonary artery agenesis with hypoplastic right lung. Yeah. What about this one? This is asymptomatic adult. Is doing well.
Vascular structures are located on the left side.
Yeah.
Posterior, the left side, the posterior aspect.
Yeah. Okay.
No discernible anterior junction line of the hem of the thorax.
Yeah. So this is all one lung, right?
Yeah. There should be an anterior junction line
True.
separating the two.
Yeah. Yeah, we see hyperinflated right lung extending from the right to the left, almost filling the two hemithorax. Yeah. So this is a case of agenesis of the left pulmonary artery. So what we see here is the pulmonary trunk and then going to the right side. So this is total hypoplasia, total agenesis actually of the left pulmonary artery and the left lung.
It's scoliosis.
Good. What about this one? This is a child with wheezing and dyspnea. This is the main pulmonary trunk.
The left is
Right.
yeah. No, left, right.
So, yeah.
The left one is okay. The main pulmonary artery crosses over to the right, and then the left returns to the left side, posterior to the trachea, because of the compression of the trachea.
Yeah, true. So here we see there is a long segment of compression of the trachea. Actually, the left pulmonary artery here is originating from the right pulmonary artery.
Oh.
Yeah. The pulmonary trunk is supposed to divide here into two large branches, which are the left and right? But here it passes as the right, and then the right gives the left. So this is a case of pulmonary sling. This is what is called pulmonary sling. What about this one? This is a young adult with a murmur. This is ascending aorta. This is descending aorta. This is a series of CT images. So what we see here that there is this structure which is passing all the way to be entering here. What is this? What is below the aortic arch? The pulmonary trunk, right? So this is the pulmonary trunk. What is this connection between the descending aorta and pulmonary trunk? True. There is a connection between the pulmonary artery and the descending aorta. So this is a case of patent ductus arteriosus. So this ductus arteriosus is usually patent in the embryological age, right? And then at birth, when the neonate start to breathe, because of the difference of the pressure, it functionally closes functionally. But then few weeks it will close totally and change into what is called ligamentum arteriosus, right? Yeah. But in this case, it's remained patent and it's carrying the blood here from the descending aorta to the pulmonary artery. What's in here? This is ascending aorta, this is descending aorta, this is the pulmonary trunk. So this is the same structure, right? Except that here we don't have contrast agent. So what is this density of? Calcification, right? Yeah. So this is a normal variation. This is a calcified ductus arteriosus. Lastly are the anomalies of the pulmonary veins. The anomalies of pulmonary veins are including the congenital anomalies in which the pulmonary veins are draining into systemic veins. Left to right shunt, usually insignificant, because in left to right it means that the oxygenated blood is going to the deoxygenated venous blood, right? But the problem is when there is increase of this shunting, it will increase pulmonary artery hypertension, right? So when there is a shunting more than 2 to 1, then it will cause pulmonary artery hypertension. So in this case, this is the superior vena cava, and this is the right upper lobe vein draining into the superior vena cava rather than draining into the left atrium, which is the normal course of the pulmonary veins. So this is a case of right upper lobe anomalous venous return. What do you see here? The heart seems to be increasing in size, right? Yeah. Particularly this portion. What forms the right border of the heart? Do you remember from the previous lecture? Right atrium, right? So probably right atrium is enlarged. What else? What about the broncho-vascular markings? They seem to be prominent, right? Yeah. And the pulmonary arteries are prominent. Yeah. Yeah. So this is a case of pulmonary hypertension due to anomalous venous return. So when there is a partial anomalous pulmonary venous return and left to right shunt, it can be insignificant. But when there is a significant shunting, as we said, more than 2 to 1, it will then cause pulmonary hypertension, as we saw in the previous case. Yeah. What about this one? These are the pulmonary veins. But there is this one. Yeah, draining into the inferior vena cava. This is the inferior vena cava. This is the liver. So right lower lobe anomalous return. The vein here is draining into the inferior vena cava. What about this one? Draining to where? What is this? Yeah, true. Yeah. So this is right lower lobe vein draining into the esophagus vein. What about this one? This is a 2-year-old girl suspected of having pneumonia.
Vascular left. Okay.
Actually, there are several anomalies here. So it's very difficult. You saw the anomalous venous return, yeah, that's true. But there is also hypoplastic right lung. If you notice here that the mediastinum is deviated toward the right side, right? Yeah. Beside, there is a right aortic arch. Yeah, which is better seen here. So this is what is called Scimitar syndrome. So what is Scimitar syndrome? It's also called hypogenetic lung syndrome or pulmonary venolobar syndrome. It has the triad of anomalous pulmonary vein return. They can return into the IVC, into the portal vein, into the hepatic vein, or into the right atrium directly. Hypoplastic lung and small pulmonary artery. So that was a case of Scimitar syndrome. This is all we have for the grade vessels and their anomalies. Thank you so much.